All right, let's jump right in. We're doing a super fast, high yield clinical revision on hyperthyroidism. This is everything you need to know for your exams and your notes, all boiled down. Ready? Let's go.
So here's the game plan. We'll start with what is it, then get into the causes and what to look for in a patient. From there, we'll cover how to diagnose it, how to treat it, and finish up with the really serious stuff, the complications and the dreaded thyroid storm.
Okay, so first up, let's get a handle on what we're actually dealing with here. What is hyperthyroidism? Right. So, at its absolute core, hyperthyroidism is a story of too much. You've got way too much T3 and T4, your thyroid hormones, just flooding your system. This basically puts your body's metabolism into overdrive. It's like the engine is stuck with the pedal to the metal 24/7. Okay, so if there's too much hormone, the big question is why? Where is it all coming from? Nailing down the cause is absolutely crucial for treatment. Let's dig into the usual suspects. Now, you're looking at this list and see a bunch of things, right? But for your exams, you need to laser focus on one, Graves' disease. It's autoimmune, and it is by far the most common cause you're going to see. Now, that doesn't mean you can ignore the others. You've got things like a toxic multinodular goiter or a toxic adenoma. That's where little bits of the thyroid just decide to go rogue and pump out hormones. Then there's thyroiditis, which is a bit different. It's more like a leaky faucet, releasing stored hormones. And yeah, even certain drugs can kick this whole thing off. Okay, so we know the what and the why. But how does this actually show up in a real person walking into your clinic? What are the telltale signs? Let's paint that picture. Since the body's metabolism is just screaming along, the symptoms make total sense when you think about it. The patient is always hot, even when everyone else is cold. That's your classic heat intolerance. They're burning through calories like a furnace, so they're losing weight even though they're eating everything in sight. They're wired but tired, exhausted from just being on constantly. Add in sweating, shaky hands, a pounding heart, and you've got the textbook picture. And this isn't just one or two things. This overdrive state hits pretty much every system in the body. In the heart, you'll see a super fast heart rate or tachycardia, and that can even flip into something serious like atrial fibrillation. Neurologically, the person might seem really anxious, on edge, and the reflexes will be jumpy. And in the gut? Well, everything's moving fast there too, so think diarrhea. The big takeaway is that you're looking for a whole collection of signs, a whole constellation of symptoms, not just one thing. So all those things we just mentioned are classic for hyperthyroidism in general. But there are a few very specific, almost giveaway signs that scream one particular diagnosis. And yeah, I'm talking about the most common one, Graves' disease. And here they are. These are what we call pathognomonic signs. Fancy word for if you see this, you pretty much know what you're dealing with. We're talking about the eyes, specifically Graves' ophthalmopathy. You get exophthalmos, that's the bulging eyes. You get lid lag, where the eyelid can't keep up when the person looks down. And you'll see puffiness or edema around the eyes. Seriously, if you see these eye signs, Graves' disease should shoot to the top of your list. And don't forget to actually examine the thyroid. Your hands can tell you a lot. With Graves, you'll usually feel a goiter that's smoothly enlarged all over. You might even hear a brute with your stethoscope. That's a whooshing sound from all the extra blood flow. Now, contrast that with a toxic multinodular goiter or an adenoma. In those cases, you're going to feel lumps and bumps. It's irregular. So yeah, what you feel in the neck is a massive clue. Okay, so you've seen the signs, you've done the exam, and you're pretty sure you know what's going on. But now you have to prove it. How do we go from suspicion to a rock-solid diagnosis? Let's get into the tests. First stop every time is the thyroid function tests, or TFTs. For the vast majority of cases, the problem is in the thyroid gland itself. It's just gone rogue and is pumping out tons of T4 and T3. Your brain, specifically the pituitary, sees this and says, "Whoa, too much," and it shuts down its own signal, which is TSH. So the pattern you're looking for is a super low, basically undetectable TSH, with sky-high T4 and T3. The only time this is different is in the super rare case of a pituitary tumor that's making TSH, which then forces the thyroid to work overtime. Now, to nail the diagnosis of Graves' disease specifically, we need to look for the evidence of an autoimmune attack, and that means antibody tests. The one you absolutely have to know is the TSH receptor antibody, or TRAB. These are the bad guys in Graves. They basically impersonate TSH, fooling the thyroid into working 24/7. If you find TRAB, you've found your diagnosis. sometimes we need a picture to see what's really happening. And that's where imaging comes in. A radioactive iodine uptake scan is like a heat map of the thyroid. It shows us where the action is. In Graves' disease, the whole gland lights up. That's diffuse uptake. With a multinodular goiter, you'll see a patchy pattern, like a quilt. A single hotspot tells you it's a toxic adenoma. And what if nothing lights up? Well, low uptake points towards thyroiditis. The gland isn't making new hormone, it's just leaking out the old stuff.
All right, diagnosis is in the bag. We know what it is and why it's happening. The next big question, what are we going to do about it? Let's walk through the 4 main treatment strategies. So first things first, we need to make the patient feel better right now. That's where beta blockers like propranolol come in. They help with the racing heart and tremors. Then we have to tackle the source of the problem. We've got 3 main options for that. We can use drugs to block the thyroid from making more hormone. We can use radioactive iodine to zap the overactive cells, or we can go in and surgically remove the thyroid. Which one we choose really depends on what's causing the problem, who the patient is, and how sick they are. Okay, let's talk meds. Your go-to drugs are going to be carbimazole or methimazole, but, and this is a huge exam point, you need to know about propylthiouracil, or PTU. There are 2 very specific times you'll reach for it, during the first trimester of pregnancy and in the middle of a thyroid storm. And with any of these drugs, you have to warn patients about and watch for a really nasty side effect called agranulocytosis. That's where their white blood cell count plummets, and it's a big deal.
So, when do we call the surgeons? Well, surgery isn't for everybody, but there are definite times it's the right move. Like if the goiter is so big it's squishing things in the neck, or if we're worried about cancer. It's also an option if the medications just aren't working. And a little pre-op pearl for you, we often give something called Lugol's iodine beforehand. It helps calm the gland down and makes it less bloody, which makes the surgeon's job a whole lot safer.
Okay, so why do we treat this so aggressively? Because letting it run wild is seriously dangerous. We have to talk about the risks of uncontrolled hyperthyroidism, including the scariest one of all. Left unchecked, this condition can do some major damage over time. We're talking about things like atrial fibrillation, putting your heart into failure, and even making your bones brittle through osteoporosis. But all of that pales in comparison to the most acute, most terrifying risk, a thyroid storm. So what is the absolute worst case scenario we need to be prepared for as clinicians?
This is it, the big one, thyroid storm. This is a code red, all-hands-on-deck medical emergency. It's not just regular hyperthyroidism anymore, it's hyperthyroidism turned up to 11. It's a life-threatening explosion of symptoms. You'll see raging fevers, a heart rate that's off the charts, profound confusion, and the patient can crash into heart failure right in front of you. And it's usually kicked off by some other stress on the body, like an infection or surgery in someone whose thyroid was already out of control. So if you're ever faced with this, you need to act fast and follow this protocol. It's a multi-front attack. Step 1, high-dose PTU to slam the brakes on new hormone production. Step 2, and the order here is critical, after the PTU is in, you give iodine to stop the gland from releasing what it's already made. Step 3, beta blockers to get that dangerous heart rate under control. Step 4, hydrocortisone to block the conversion of T4 into the more potent T3. And all of this is happening while you're providing major supportive care, like IV fluids and cooling blankets. You have to know these steps. They can save a life. And that is your crash course on hyperthyroidism.